definitely a lot of what people are using on the ID side, since coronaviruses themselves have been known agents before, there's a little bit of information. Although as people study this, the COVID-19 behaves a little bit differently than other coronaviruses. Lots and lots of information about this around influenza, which it shares some characteristics in how it behaves. And that's part of the issue, is everybody's kind of guessing on it. Anybody in the class have any questions, comments? And you have the option of either unmuting your microphone and talking, or you could put questions in on the chat side of things.
I kind of have a question about, so I've been watching the news and I see all these kind of different like drugs and therapies coming out, but I have no idea, what I guess is the most promising option. Is there anything that you all have seen that you think might be the direction that we end up going?
No. I think, there was some initial talk about Kaletra, the HIV medication. That was helpful. I think that's fallen a little bit by the wayside. Hydroxychloroquine is sort of still out there being investigated. Zithromax is still being investigated. So there's a whole bunch of different medications out there. Initially someone said, well, don't give the patients anti-inflammatory medications like Motrin or Aleve, things like that. And that turned out to be like nothing. So we're still occasionally using that for patients if they need it. So, as far as transmission, things like that, that's one thing, right? But to truly do a good study that shows efficacy of a treatment pathway takes much longer. And you have to determine, you have to have a cohort that's being treated with the quote-unquote standard method, which really doesn't exist for this. So I think, to be honest, I would just kind of search around and see and be skeptical about what you read, right? What is it what makes sense? Try and look at some reputable sources when it comes to hearing, what's out there and what. Someone said the other day, this came up in a town hall meeting we were having. Someone said, well, make sure you take zinc, and we have at Grady some of the world's experts on infectious disease. I don't know if you guys have heard the name Carlos Del Rio, but he's at Grady, and he's the one who's doing all these, national things. And he's like, that sounds like a bunch of hocus pocus to me. He's probably right, but there's probably a 1% thought in my head that is saying, well, maybe this will end up being something. Just no one knows right now. So try and find reputable sources and take everything with a very large grain of salt.
Okay, thank you.
Yeah, I agree completely, and I wanted to add to that, when you go to those reputable sources, you actually need to look at their statistical analysis section and see what they actually did with the data. We talked about that in class last week, that the first study with hydroxychloroquine, when you started looking at their methods and their statistical analysis, they actually specifically removed patients who got sicker out of the analysis. One of many problems with that particular publication. So even in reliable journals, sometimes the data doesn't quite mean what it seems to mean, unless you really dive in a little bit about what their analysis is. The other thing to be aware of as we start looking at drugs is that many of the impacts may be relatively small. So a 5 or 6% difference in outcomes may be significant enough that we're going to be using a drug, but may not really be the cure that everybody is sort of hoping for and wishing for at this point.
I have one more question about our presentation, if that's okay.
Sure, go ahead.
So, in terms of the doffing and donning part of our process, should we still focus on that? And like, even if we do, should we just get different procedures for different types of PPE just as part of the proposed solution, which would be like a resource that different doctors potentially would look at, if the solution actually were to come to something?
I would say this. So, I mean, I'll share a little bit with you. We have now a scrub machine for us in the ED, which means that people can come to work in regular street clothes, go to the scrub machine, get out a set of scrubs, put on the scrubs, work, go in the locker room, take off their clothes, put the scrubs in a dirty bin, put back on their clothes, and go home. So I think it's more than donning and doffing. When I sort of bring my own clothes and save the scrubs for the other people, I change in my office before I go home. When I go home, I get undressed in the garage. I put those clean clothes I put on in the same bag as the dirty clothes. I walk to the laundry room. I put it in the washing machine without touching the clothes, right? Because there's fomites on it. I then walk to the bathroom that's 6 feet from our garage door, and I take a shower there. I don't walk all the way to our bedroom our bathroom to take a shower. So it's more to it than donning and doffing. If we're really going to focus on preventing bringing it home, like Dr. Ackerman mentioned, what other things? Like, is there any literature out there about showering at the hospital versus showering at home? I think most everyone I'm talking to is either showering at work in the limited number of staff showers that we have available there, or they're going home and immediately taking a shower. Most everyone I know is getting naked in the garage, and it sounds funny, but it's how nervous we are about bringing it home. Fortunately, everyone in my family is healthy, but we have some faculty that are older, and some faculty that are taking immunosuppressants for one thing or another, and some faculty that are pregnant, and so there's these special groups as well that we're very concerned about. So if you're really focusing on not bringing it home, I think in addition to donning and doffing, you need to focus on the sort of end of shift process for, I guess I'll say, disinfecting yourself,
Okay, so don't focus as much on the PPE itself and the process for removing that PPE, because that's kind of complicated and will vary based off the hospital supplies, but more so focus on those disinfectant processes you talked about, aside from donning and doffing when you're leaving the hospital, and then what you do when you come home.
I think it's a difficult question because, and I'd like Dr. Ackerman to chime in, but if you're at work and you're not careful, you'll get sick, and no matter how much you bathe yourself, you'll bring it home, right? Because you're sick, and it's inside of you, right? Yep. If you are careful at work with donning and doffing, but you happen to contaminate yourself when you're on your, and you bring it home with you, and you don't carefully, you walk in the house with your shoes on, and you go in the kitchen and get something to drink. Well, then you've just contaminated the handle of the refrigerator, and now your kid has come along and grabbed the handle of the refrigerator, and now they're sick. So there's more than one way to transmit it at home. One of the ways is by not being careful in the hospital with doffing, you get yourself sick at the hospital, and the other way is you bring it home on your clothes and you give it to somebody else. But Jeremy, can you chime in? I don't want this to be so broad for you guys that it becomes undoable, but that's at least how I think about it. Number one is don't get myself sick at the hospital. Number two, don't bring it home on anything I'm wearing.
Yeah, I agree. To me, the donning and doffing is something that, at least from our experiences with Ebola and other things, we sort of know how to do that, and hopefully we're doing that correctly and wearing our PPE at appropriate times. But I think for most of us, there's this big question mark of, okay, I'm not infected, but I am likely contaminated. in small amounts, or my clothes or other things that I'm bringing home, and how do I avoid those secondary risks of exposure of my family or exposing myself. So your comment of how you put your clothes into the washing machine without touching them, right? It's not enough to simply just put the clothes in the washing machine. You need to minimize contact with it before they are effectively cleaned. And there is a bit of this that part of it is managing perceptions about how careful we're being. I know a good bit of the conversation with my family. There have been some requests to do things that I don't believe make any difference whatsoever, but everybody feels better if that's what I'm doing. So we're approaching it.
Would you recommend that they narrow their scope a bit for this? And if you do recommend it, to which parts should they narrow their scope? Or do you keep it broad?
So I probably would avoid specifically making recommendations around the doffing and donning. I think that it's important that you do a little bit of research and understanding doffing and donning, because some of these risks of what gets contaminated on us may come out of how the doffing and donning process is done, whether it's being done correctly or not, and what parts of us have some additional risks of exposures. It might be a good idea to focus in a little bit further as you start looking at the enormity of the problem, and pick either, say, the what I'm going to do before I leave the hospital, or the what I do when I get out of my car and get into my house. That may give you a little bit more focus, that makes this a little bit more addressable. Because, this is a big problem. And to a degree, I think anything that you say that comes out of this that's meaningful, that actually looks at what we actually know about transmission, would be an important step for us. Melissa, are you getting ready to cut me off?
Yeah.
All right, fair enough.
Cool. Next group is blue collars, if y'all are ready.
Yeah. Can you hear me?
Yeah, we can hear you.
Oh, so we pre-recorded our video. Is it okay if I screen share?
Yes.
Okay. Hopefully this works right. Okay. Can you see all of that? Hello?
We can see like a blue screen, if that's right.
Hopefully. I mean, is there any writing on it? Does it say, or is it just like blank?
Mine's
it's like
just
the
blank.
blue screen we saw last night. Maybe just try playing it.
Okay. That work? If not,
No.
I can just...
Oh.
Okay. I have the Google Doc, or the link for the Google Doc. I can share that. Oh, it did? Oh, okay. It appeared for a second, apparently. I'll try it out again. Sorry. It worked last night, so... Okay. Okay. Take two. Alright. Hopefully it works.
This is Team Blue Collars. I'm Jaden Sen.
I'm Ashley Wilson.
And this is our COVID-19 assignment. But as you'll notice, there's not a lot of text on it. just going to ramble in order for us to get to the next slide. It seems that I still must continue talking until we do that. Well, I'm hoping you guys are having a nice quarantine time. Okay, here's our problem statement. Due to the current COVID-19 outbreak, going into the emergency department can be perceived as dangerous for people who are not experiencing COVID symptoms. Often these patients will forgo visiting the doctor in order to avoid risk. We have two memes here. One of them is talking about why you need to wash your hands, or I guess what happens when you wash your hands that many times. The other one's talking about the importance of flattening the curve.
So some personal observations that we've noticed in our own lives is June's mother was afraid to go to the hospital when she felt a little sick. My mother also delayed seeking care for about 2 weeks due to fears of coronavirus and catching it from other patients. My grandfather should be starting treatment, but they don't want to go to the hospital right now due to COVID risk. Ben's sister works at a local hospital, and she feels like she's risking getting COVID every time she goes to work as well. So there seems to be a lot of,
Because we couldn't go to the hospital. Either die than going to the hospital. And she was a patient with, as you know, is very severe and had to go to the hospital. Never heard from her. Also a doctor. Our literature review found that their time from when they 5 minutes to 300. And so one of the factors that medicine has been shown to be just as effective.
So telemedicine allows for hospitals to outsource work to physicians who might be quarantined at home or otherwise unable to come in, to outsource it to other hospitals or hospital systems, to specialists, and to a broader range of sources than they could otherwise. It also, as we would want, reduces physician contact with potential COVID patients, as well as reducing potential contact between patients that may have COVID and those that don't.
The solution is manage of the system, outpatient hospital in the first place, and if they don't, be able to receive, and we'll be able to resort him. This is the current process diagram of the Dutch system. So all patients are screened by body temperature and are given this set of screening questions. And if they answer yes or have fever, they are labeled as COVID PUI and go through a separate process. Whereas if they don't have fever and the answer no, they go through the standard. So with their telehealth survey system, we'll be able to first identify whether the patients do need to come into the hospital in the first place. And if they do, they will be surveyed by telehealth to be identified as potential COVID PUI or potential non-COVID patients. And they'll still be screened, but they'll be separated at arrival in the first place. So there will be less contact for both patient side. So for our potential unintended consequences, there are several negatives. Those without internet access must still go to the hospital. There could be a possible reduction in workforce to care for the sick. There could be a low return on investment. It may cost more money to implement the solution than it would be to get money from it. There could be there could be issues with insurance billing as well as security breaches when it comes to. However, there could be increased cooperativity between hospitals.
Okay, so it's finished. Were there any issues with it, or I guess like receiving the video?
The audio cut out a lot, right?
Okay. I guess we can try to explain anything that you might have missed, or if you want to replay the video, that's also fine.
Yeah, if you can either put in the chat the link or put it on Canvas, the link to your video, that might let us watch it separately and give you some additional feedback. Although I think, even though the audio wasn't great, I think the high points came through fairly well. Let's jump in on a little bit of feedback. Does one of you, can you pull up with the share screen your problem statement?
Yes, I could do it. I just need to
Okay.
drive.
While you're working on that, so I think your kind of direction and your understanding of the problem is actually reasonably good, but I think the observations, and I would applaud you for using observations taken from your own personal and family experience. All right, right now that's where we are in terms of understanding some of the issues that we're facing is, what is actually happening, and there are not as reliable other ways of getting good data to go along with it. So I have your problem statement up, and you say, due to the current COVID-19 outbreak, going to the ED can be perceived as dangerous for people who are not experiencing COVID symptoms. And I think the big nudge here that your observations point out fairly specifically is it's not just the ED, it's really going to any sort of healthcare setting. Right? So I will throw in my own personal experience. My family members had a couple of routine prescriptions that needed to be refilled, and my wife really didn't want me or her to have to go to the pharmacy to pick up the prescriptions. And part of that is based on the perception of who goes to the pharmacy to pick up prescriptions. People who are sick. And who's sick right now? People with COVID-19. So I think that broadening your problem statement about more broadly not wanting to participate in healthcare, as much as, yes, I normally want you to keep it ED focused, would be a wise thing to do. Particularly since then you say patients will forgo visiting the doctor. Presumably you mean their regular healthcare environment. Part of why I'm nudging you this way, I had a conversation with one of my colleagues, one of the faculty in emergency medicine, who kind of rhetorically asked the question, since right now our ER patient volumes are much lower than what we normally see. She said, where are all the patients? And we kind of looked at each other, and we're starting to get data from New York coming out. And I think right now the answer is they're staying home. And in some cases, and not just because of COVID-19, they're dying at home. Whether that's because they're not getting medications they should have, they're missing treatments that they should have. So I think this is a really substantial problem that we're facing in medicine across the board. And, going to the ED is probably specifically a problem for people who are really at that point of getting ready to die or getting much sicker. But the bigger problem and the bigger place where an intervention of using telemedicine is going to help is sort of all those people who are supposed to be doing something with healthcare anyway and are now deciding not to.
Okay. Yeah, so I guess one of our issues was trying to decide whether or not we should focus specifically on the emergency department, because we wanted to try and keep the focus around Grady and Emory. But yeah, thank you for the input. I think that it is important to talk about more general use cases in hospitals and such.
Yeah, I mean, I think that there's a couple ways to look at this. One is, like to Dr. Ackerman's point, and this is something we're looking at Grady. So there's, the way I sort of think about it is there's sort of three fronts to this, right? There's the patients who would normally go to a clinic and aren't going to the clinic as well because very often the clinic's been closed. or they're just afraid to go to the clinic. So there's a use case there for telemedicine. The second group is the people who are either being, sort of the hospital focus group. Either the people who are in the emergency department who aren't sick enough to get admitted but have concerning symptoms who are going home, and you'd like to sort of monitor them at home. There's another sort of subgroup there of people who are coming into the emergency department, really who have nothing wrong with them. We're trying to avoid contact with them, and that's sort of within the ED telemedicine. So you can have, me sitting in my office in front of a computer screening sort of these low acuity people who are walking into the waiting room and sending them home to minimize my exposure. And then the third group you have is the group that is being discharged from the hospital, in some cases earlier than we may want to discharge them for space reasons. And you'd like to kind of continue to monitor them at home because these patients are getting very sick very quickly. Sort of they're falling off the proverbial edge at times and getting very sick. And then the third group is employees. So there's a product that we're using at Grady, which, I'm sure, I hope it's okay to mention. It's called Vivify. And we're using that, it's Vivify, Vivify. And that we're starting with the ED staff and I think also the ICU staff, where they're going to basically download it to their phone, log their symptoms on a daily basis, and the employee health will sort of has some sort of software in the background that runs and says, this person's having some concerning symptoms, and then you can have a call with them or whatever it may be. And so that's certainly sort of another group where telemedicine can come in handy, sort of the employee health aspect of it, because healthcare workers are getting sick. So there's a lot of options here. You mentioned something about billing. There's been a lot of expanded billing codes for this kind of thing because they realize that a lot of people are using it. It's not like you can just sort of grab it and start using it. There's some requirements from a state perspective, which if our senior business manager haven't sent it to our faculty yet, she will be shortly. But our advanced practice provider, so our nurse practitioner and PA group, has already had to get that done and filled out, and then I'll have to sign off on our ED protocol for it. So there is some requirements to do this, and you ought to look into what that involves. But there is billing that's now available for it, and that's been in the news and things like that. So there's a lot of different ways to go with this. Again, I defer to Dr. Ackerman if he thinks we ought to narrow the scope a little bit to focus on one group in particular. It sounds like, a lot of the things here, a lot of the things you mentioned really are people afraid to go get healthcare. And you sort of indicate that these people may, or more than likely have a primary care physician. So is it worth looking at people who are not getting their regular medical care because they're afraid to go in to be seen? Is it people with symptoms who, they sort of self-triage them to being low acuity symptoms, and therefore just need someone to evaluate them, sort of a nurse call-in line, but have it be a virtual visit? So I defer to Dr. Ackerman on how broad or narrow we want the scope of that to be.
Yeah, thank you very much for that. We definitely had a little bit of an issue with trying to decide the process in which we were to, send people that would have potential symptoms. We also tried to think about patients that, because we were thinking about this in terms of the emergency department perspective, in terms of patients that would need to still get to the hospital in emergency situations, and such things like that were, well, not necessarily clearly not COVID symptoms, but would have a more precedent case, such as someone that may be having a heart attack or another serious event. But
yeah, so there's a lot of ways you can go with this, and I think, I think with Dr. Ackerman's input, you may just want to decide, how broad or narrow you want it to be.
Yeah. In that case, so in terms of, I guess it makes a lot of sense to focus on people that may not also have emergency situations. But this is for Dr. Ackerman. But how far should that be in that instance? Is it people that would like to get refills on prescriptions, or is it people that just want to call for a checkup, or is there like a particular line that should be drawn in terms of like the usage for this type of system?
This is kind of a brave new world right now. And to a degree, your framing of the problem puts you in a position to decide what you think is most appropriate. This is not a situation where there are right answers. So Dr. Atala gave kind of a list of a whole bunch of different sort of usage cases for using telemedicine. And the question becomes, what do you think the problem is that you most want to address? Is it essentially getting basic primary care, ongoing care to keep people healthy enough to avoid having to worry about emergencies in the first place? Do you want to start getting a little bit more into those emergency situations and the I'm sick, and we use some sort of a telemedicine type process to further triage, provide some degree of care for folks who have new symptoms. And your choice of what you think the problem is really is more about which problem you want to address rather than which is really the problem. All of those usage scenarios are actual problems. Some of them may have big differences about who you need to be providing the care, whether it's a nurse, a APP, one of our nurse practitioners or physician assistants, or whether you need an actual physician. I'm going to throw out there that Grady's primary care clinics has actually been using medical students basically in a call center format to reach out to patients that they would normally be seeing in the clinic. And a big part there is sort of screening who simply needs refills and things like that a physician can go in electronically and click a couple buttons and do, and may not need to directly interact with the patient, versus folks that really have a more pressing issue that requires a higher level of care. There are a lot of different models. Because you've got some family members who are directly facing this problem, you might want to think about framing the problem in a way that addresses those people's needs. That way you can get a reality check on whether your solution seems like it would be useful, palatable, all of that. And you may be able to reach a little bit out with those family members and find out if you can talk to those family members' doctors about their view of using telemedicine, telehealth processes to try to care for these patients that you know as your family members.
Thank you for that.
Yeah. We are recording all of this, so some of the things, hopefully I'm saying a few pretty smart things. I'm just going to throw out there, Dr. Tala has said a number of pretty smart things that went by pretty quickly, so it may be helpful to go back and find the appropriate things in the recording, and just that way you can actually write down exactly what we said, because there have been some good points that have been made that may have gone past all of us just in the conversation.
I'm just glad it was recorded that I actually said something smart for once. That's it. Marissa's chomping at the bit to keep us moving, it looks like.
Yeah, I gotta cut you guys off. So Grey's Anatomy is next, if you guys are ready.
Okay, I can share my screen, so we're gonna do this live. Are you able to see it?
Yeah, we can see it.
Okay, cool.
Okay, can everybody hear me? anybody hear me?
Yeah.
Yes, we all hear you.
Good. All right, so this is Grady's anatomy presentation on the COVID-19 emergency department triage and testing process. So our problem statement is with the need for increased testing in the United States, shortages in PPE, and the problems associated with working in contingency care spaces, there needs to be a safer and more effective means of testing individuals suspected of having contracted COVID-19. So we wanted to start off by just looking at some of the testing statistics because there's lots of testing at lots of different locations, one of which is emergency departments. And so you can see here that there's been well over 1 million tests done in the United States, and most of those are done in commercial laboratories, but there's also a large amount done in public health laboratories and clinical laboratories. And then going further into looking at the testing statistics, you can see that the United States is still pretty far behind other countries in per capita testing. So this just shows that we are still in the process of ramping up our testing, and there is still lots of testing to be done. And that's also shown on the figure on the right, where you can see that there has been a ramp up in testing, but there's still more that needs. And so looking at PPE, there's lots of journals that say that there's not enough PPE. That's pretty well known. But this has been resulting in high rates of infection for healthcare workers, particularly in Italy. Because of this, the CDC has stated that we should start using contingency strategies. And the main thing we're looking at here is the maximizing the use of engineering controls.
So as far as PPE that's required during testing, testing is an aerosol forming procedure. The quote at the bottom is from when they were doing a drive-through testing location, and lots of things like this have been reported where it causes people to sneeze or cough. So you have to wear lots of PPE, and a lot of that is not reused. Our next point about the contingency framework, so Grady right now is operating under a contingency framework, and they've acknowledged that there is a potential for crisis standard of care. So already staff are being spread thin, and there's the potential to have too many patients for the number of caregivers. So going into what they're actually doing at Emory and Grady for triage, so they're categorizing people as either low, intermediate, or high risk. At Emory, if you're intermediate or high risk, you are isolated in a separate waiting room, and then from there you'll be processed. Low risk and intermediate or low risk people are typically discharged. As far as Grady goes, they do a similar thing, but they are putting almost everyone in a room for the most part. But the thing about that is they have to wait in waiting rooms, so you aren't moved into your zone until there's a room available. In the testing procedure, it's pretty much the same at both. It requires a lot of PPE, lots of paperwork, doing the actual test, and then putting it in a biohazard testing bag, and then sending it to the microbiology lab. But at Emory, they do the testing before you're in a room, while at Grady, they wait in the waiting room until they're placed in a room to do the testing.
We also looked into cleaning solutions and techniques used for patients, for rooms with coronavirus patients. And we've listed a few of them with their contact times, which is how long the solution must be wet on the surface to disinfect that surface. Also, fogging is used, which is aerosol particles to disinfect a surface. So our proposed solution is using a glove box that is telephone booth size, and this is disinfected after each testing. We're basing this off of traditional glove boxes, which are used in labs and have interchangeable gloves so multiple people can use them. Also have vacuum chambers, which can be used to remove aerosol particles within them. So this is a diagram of our proposed solution, in which patients would enter and be tested using the glove apparatus. Then they would exit, and the room would be disinfected using the aerosol spray. And then afterwards, they would retrieve the test kit. Some unintended consequences are that the hospital will have to front the cost of the devices as well as disinfecting them. Also, the staff would need to be trained on how to use the device, and also the device takes up a lot of space, and if it's not cleaned properly, it can result in more infections than less. That concludes our presentation. Are there any questions? Or feedback.
All right, so Dr. Atala, do you want to get one of these to maybe put in RES so that we can turn around rooms there a little bit more quickly?
I mean, I think this is something, especially if volume starts to ramp up, this is perfect for the worried well, where you actually want to, and I use well loosely, but where you want to actually test them, but they're not that sick based on, very brief triage evaluation. I think, there's a couple, I don't want to say concerns, but I think considerations, I'll say. Number one, getting tested for COVID is uncomfortable. You basically have to put a Q-tip into a person's nose as far back as it will go until it stops, which is pretty far, and it's very uncomfortable. And the other thing is that the smaller Q-tips are on national back order, so we're having to use not like the kind of a regular Q-tip you have at home, but it's smaller than that. It's sort of a sponge at the end of it, but it's still bigger than what we normally have to use, and it's more uncomfortable. So people are going to naturally want to pull their head back. It's easier to do with them sitting in a chair or a stretcher where they can't move their head back. And so, in lieu of sort of reaching behind their head and grabbing the back of their head while you do this testing, I mean, it's something to consider, the whole testing process. The other thing is, how do you know, once that room has been sprayed, basically it's that disinfecting process, and how the space gets clean. And you really have to be sure that it's clean. Otherwise, you're telling someone you're gonna, go into this room, you're gonna get tested. I would immediately be thinking to myself, well, how many other people who are potentially infected have been in this room before me? And what assurances do I have that this room is actually clean and that I'm not going to get sick by going in this room? We were in was it Paris last fall, I think it was. And I was amazed by these public bathrooms that they have, where you walk in, you do your business, and then you leave, this door closes, and then there's this whole magical disinfection system that happens, while the doors close to prepare the bathroom for use by the next person. And so, does it take more than just sort of spraying this mist of bleach or whatever it may be, to clean the room? The other thing is, and I sort of picture in my head, you'd have to give the patient the testing material and have them hand it to you in your gloves when you walk in. Again, not that big a deal, but something else to consider. So, it's a good idea for these sort of rapid testing things. It helps prevent aerosolization, getting out. They're basically in this enclosed box, but it's got to be clean. I would be nervous, not knowing about this, of walking into this space that, that I'm the 60th person to get tested in that space one day, and then we wouldn't want this to eventually be a vector for transmission, right? So it's one other thing to consider. The concept is great. How do you test people and really minimize exposure to providers and not having people having to don and doff what limited PPE we have every single time? But the concept is a really good one. It's just how you apply it and how you operationalize it. I think that's requires a bit more thought.
Yeah, I agree. The biggest problem that you actually have with your presentation, you kind of lost me from your problem statement. And part of that is you can probably fix with changing one word. So you have in your problem statement an effective means of testing individuals suspected. And I assumed as you were presenting that what you were talking about was, are we doing antigen tests or PCR, or what type of test are we doing? What you're really addressing is specimen collection specifically. And so I would adjust your problem statement to have that focus. once I know that that's what you're focusing on, much of the information that you're providing actually forms a coherent story that leads up to your solution. I agree with Dr. Atala 100%. The fundamental concept addresses a real need. There are a lot of issues of the details of how you're going to do this, how the patient is going to do it, dealing with claustrophobia. Patients run away from you when you start jabbing the swabs up their nose. There are related procedures that I'm sure you can find YouTube videos or videos of us collecting these specimens that you probably would want to look at and add to some of your observations to understand what additional modifications you might need to this solution. But you've got a lot of good pieces there. I would develop kind of your understanding of some of the issues Dr. Atala mentioned about cleaning and perception and how we get our tubes and our specimen collection in and out and still provide the benefit that you're looking for.
Okay, thank you. Yeah, we definitely need to look at the actual, or specify more the process that we had in mind for getting the test in and out of that unit.
There are a lot of other setups that you'll see in labs and things like that are aimed at addressing this. So, a lot of times in doctors' offices or in medical labs where you come in, particularly with needing to give a urine specimen, you walk into a bathroom that has this little airlock kind of thing by the door, and maybe the vials for the urine. Sometimes you walk in, some labs that I've been into, there's just a basket of the vials sitting there. So there may be a lot of things that you can look at what people are already doing in other contexts that may help inform your design a little bit further.
Okay, thank you.
Okay, thanks for the feedback.
Yeah.
Cool, okay, so last group is group 1, if you guys are ready.
Yeah, we recorded a video so I can share my screen and see if I can get that to work.
Cool, perfect.
And if you can post the link to the video, if it's somewhere in the cloud, that would be awesome as well.
We submitted on Canvas too, so it should be there on the assignment as well.
Perfect, thank you.
Can you guys see this?
Yeah, we can see it.
Okay.
Is there supposed to be audio with this?
Oh, is the audio not on?
Not hearing anything.
Okay, that's a problem. Let's see.
If you have headphones in, maybe just unplug the headphones and play it out loud. That might work.
Yeah, we'll try that. My audio cut out too. Was that not working too?
No, that wasn't playing the audio either.
We can just present them on the slides then, I guess, and just read our script from the slides.
Okay, we won't hold some mistiming against you.
Okay.
can everyone hear? Can you hear me?
Yeah, I can hear you.
Okay. Hold on. Okay. Hello, everyone. We're Team 1, and we're going to be talking about the donning and doffing of PPE during the COVID-19 pandemic. So we're focusing specifically on the donning, putting on, and doffing, taking off of N95 masks because it is the step that results in the highest risk of contamination to the user. The shortage of proper masks encourages the extended use and reuse of N95 masks, which further increases the risk that this process poses. The masks in question are the 3M 1860 N95 respirator masks with 2 straps, and in long-term use, contaminants will accumulate on the front surface. Your problem statement is that donning and doffing reused N95 masks result in a high risk of contact with surfaces contaminated with SARS-CoV-2. In literature studies which didn't actually use N95s as a medium found that the virus can last as long as 3 days on plastics. Also, the functionality of these masks mean that the longer they're used, the better filtration they'll have, but with a dangerous increase in concentration of the virus at its surface. To remove these, the CDC recommends grabbing the straps, bottom then top, to remove the mask safely. However, a study attempting to replicate the doffing procedure found that 100% of subjects contaminated their head and neck area in trying to grasp the straps, which can be associated with improper doffing technique and the difficulty in locating the straps.
So from talking to Dr. Ackerman, we found that throughout the donning and doffing process, the biggest risk point is when the staff has to remove their face masks. And the fact that the surfaces of these masks are so contaminated means that it's really crucial that they're handled carefully without touching the front of the masks or on the user's face. And so when reusing masks increases the frequency that this risk occurs in the donning process as well, because the staff will have to don with contaminated masks now. And looking at the Grady SOPs, they said that the N95 masks need to be worn at all times in the ED and only be discarded when they're visibly soiled or damaged. That means that a lot of the healthcare workers are going to be using very contaminated masks up until the point where they're physically not usable anymore. And the CDC has similar recommendations. Even though the mask is supposed to be disposable and for one-time use, the CDC will allow reuse by the same individual as long as it maintains proper fit and function, which again is just up until it doesn't work anymore. And so, these guidelines kind of promote frequent donning and doffing using contaminated masks. And so we want to add 2 main improvements to the overall process here. The donning phase is going to be the same as the regular SOPs, but we want to add these tabs that you'll see later onto the masks to help facilitate the doffing. And then they should be stored in between uses by the recommended standards using breathable containers. And we also want to add a sterilization step after the first storage, and then we have to store it afterwards so that we can separate the sterile and non-sterile masks to be reused. And so these are the tabs we were talking about adding. We found a study that added 2 vibrant red tabs on the top and bottom straps of the masks, and they found this facilitated the ease of doffing and reduced the risk of contamination and a lot. And they also served as a visual and tactile reminder since they're so visible. It was a reminder to use proper doffing techniques and not touch the front of the mask. And we think that this step doesn't add an extra step or any extra complexity to the doffing procedure, which we think will make it easier to implement.
Okay, so the second part of our solution is to sterilize masks at 121 degrees Celsius for 15 minutes. So this procedure will incorporate a dry sterilization process as well as a regular steam process with a mask in the sterilization or laminate bags. So the study concluded that this process can sufficiently inactivate the virus. And researchers also found that the sterilization process did not influence the functionality of the masks. And we also identify some other steps that can help to optimize the effectiveness of our solution. We want to adhere to the policy that of extended use over more reuse to reduce the physical damages on the masks. The reused masks need to be properly stored in a well-ventilated container with the usernames and date after sterilization. In order to identify when the mask should be disposed of, the seals need to be checked using a breath test, and each mask should not be used for more than 8 hours for single use, and each mask should not be reused for more than 5 times. So our intended consequences are first, so these additions, they do not interfere with the recommended PPE donning and doffing techniques. And second, the doffing will reduce the contamination around the head and neck area. And third, so when donning, the user will reuse a sterilized mask, which poses a lower risk of contamination. For the unintended consequences, it includes the possible degradation of the mask during the sterilization. So the users may experience some discomfort, or they need to reposition the mask, which may result in contamination. Also, by adding sterilization processes, measures should be taken to keep the mask sterilized. So this is a reference.
Yeah, so this is another hot topic, and there's a lot of, early on there's a lot of emphasis on, like, don't touch your face, all this other stuff. For anyone who's tried to wear an N95 mask for even 4 hours straight, it's miserable. We have people walking around with Band-Aids over the bridge of their nose just because of the irritation of it. I went to take a break during one of my shifts, and I went in my office and took off my mask and took a picture of my face in a little mirror we have in the office, and, like, bridge of my nose was red, it's extremely uncomfortable. Prolonged use is, and I want to make sure I understand what you're saying, which is prolonged use is obviously preferable to reuse. Which at first it didn't click on me what that meant, then I thought about it. And so I agree with you, but the reality is I think reuse is going to have to be an issue. We have N95 masks now, but I think the concern is if we start doing single use, we're going to run out in no time at all. So that's why we're still trying to encouraging reuse. I think then the other conversation that's come up quite a bit is, well, how do we clean these things? There's been discussion about UV light, which I think, at least my suspicion is that it's less degrading than a steam or dry process, but I obviously don't know that for sure. There's a lot of Grady is currently looking into trying to get something that would allow us to clean masks. But again, having large sort of wholesale things that can clean 100 masks at a time, that's been a little bit more difficult to find. So it's a good concept. Again, I think trying to figure out how it can be done best and most safely is important. And then really coming up with a way, is there a way to somehow disinfect it before the person takes it off, so that you're not contaminating your hands and all that other stuff? That might be a possibility. I don't know. It's something to think about in terms of reuse of these masks.
Yeah, so I would like to point out you've got a very nice, simple problem statement that, really is quite striking for all of us who are running around wearing these things, because I think it's something that most of us have some concerns about. I realize that my process, as best I can tell, to safely remove an N95 actually requires use of probably 2 sets of gloves to be fully, minimal risk of not transmitting. In terms of your literature, you do need to be a little bit cautious with some of your literature. And one of the things that was on one of your slides, and to your credit, you correctly reported what the source did, but your source about sterilization did not actually test sterilization for COVID-19. I think they used staph, so bacteria, and on your slide you said that there was no detectable bacterial load. Unfortunately, bacterias and different types of viruses can respond very differently to different sterilization methods. So just because something worked well against staph does not necessarily mean it's going to be effective against a viral agent. Your literature search right now looks like it's kind of a preliminary one. I would dive in a little bit more into different sterilization methods and just double check that they're talking about sterilizing against something that is either COVID-19 or something that is closer to it. As much as I usually don't like having multiple solutions, unfortunately, I'm going to give you some ground on this one and say this is a problem that probably needs a multi-step solution, so more of a process solution. So I would encourage you to think about what does the process diagram more specifically look like. I know you have the pictures, but how are you modifying it? The adding the tabs to the straps is actually something that while I was using a disposable N95, I actually put extra pieces of tape on my straps to make it easier to find those straps with less contact with the mask. I think it's a good idea and actually something that we could probably start recommending that people do immediately. It's essentially a no-cost thing that may decrease some of the contact.
Hi, Jeremy. This is Richard Wang. I joined late.
Welcome to the group. I don't know how much of the presentations you were able to see. Did you have any feedback for this group, or if you saw other groups?
Yeah, I just on the last one. Maybe I'll tell you the story later. But on this last one, I will quickly suggest that the group hop online and pick up the quick consultation that the National Academy of Medicine just issued this morning. I just got the email this morning about this area, but I belong to another listserv on this issue, and there's been various recommendations going back and forth. The one leading one that appears to be working right now is one proposed by Battelle Memorial Institute, and they're actually put into place, I think it's called vapor hydrogen peroxide. They have the whole system set up, and some centers are actually using, such as the one in Boston. The most practical one that I've heard about is what I would use is to issue every healthcare provider 5 masks, 5 N95 respirators, and you put them in separate paper bags, and you date them when last used. The last time you used it, let it sit there for 5 days without touching it. The persistence of the virus should be gone by then, and then you just recycle them every 5 days.
Yeah, that's something that also Dr. Ackerman did mention about, like, alternating masks can help them last longer, and it's really good that they have this information out now too, because we were struggling to find people that actually implemented like a full process like that and had it show evidence. That's why we were just looking at steam sterilization with the UV a little bit too, because we were just trying to work with what they had so far, and a lot of it hadn't been so reliable. But it's good that they have something like that figured out now that we can look at.
Yeah, and Dr. Wang, he's noting that this is something that came out literally this morning. Is something for everybody to bear in mind is recommendations, literature, data is coming out on a day-by-day, hour-by-hour basis. So there is a chance that, just because you may have a good set of references right now, by the time it's time to turn everything in, things may have changed. There may be more information. I don't want you guys to, get totally distraught when you find out that information has come out that has superseded everything that you were working on. But I would like you to at least, if you know that additional data exists, at least acknowledge, well, here's what we think right now, but this morning a new guidance came out that goes in a different direction. All right. If there are no further comments or feedback, that was our last group for today. I'm happy to hang on the line and continue on and start doing office hours. If there are other providers on who are interested in hanging out and chatting with students, you're welcome to do so. And I will go ahead and stop the recording so that we can have something that hopefully I can post out to students that weren't able to make it onto class today.
Thank you, everyone. Great job.
Recording has stopped.
Dr. Ackerman?
Yep.
I had a quick question about the patient write-up. So,
sure.
I watched a couple of the episodes from Grey's Anatomy, and I was looking at the example H&P that you linked, and I was wondering, like, how specific would you want, like, the numerical data, like, allergies, medicine, do you want us, like, make up allergies that they might have, or do you want us to just exclude that from our write-up?
So